So in order to prevent urinary morbidity, we need to recognize high-risk situations and tailor either our treatment or our patient selection based on these scenarios. And I'm going to show you some data from our 10-year urinary symptom experience, and then later on I'm going to show you some data from our 15-year experience, which will be published hopefully soon in the British Journal of Urology. So at 10 years, we reported this very favorable data on almost 2,000 patients who had completed close to 12,000 IPSS urinary symptom sheets. And you can see when you look at mean scores that there's really very little change between the initial score, which was 7.4, and the score 10 years later, which was 7.8. And the other thing we took a look at in this study was how do patients do if they present with minimal, moderate, or severe symptoms, keeping in mind that we had been taught early on that if a man has a AUA symptom score of 20 or greater, so he's got very bad symptoms, that patient probably should not be implanted. And what we found, in fact, that when you looked at the baseline score and you look at the score 10 years later, it was 11 points less. So actually those patients improved substantially when they had an implant. They didn't get worse. In contrast, what was happening to the patients who had minimal symptoms is another issue. And you can't really see anything here in this graph because it doesn't really look much worse. But that was an area of interest of mine, because if you're taking a patient with minimal symptoms and he has minimum symptoms 15 years later, he's a very happy guy. But if he gets worse after 15 years, then he's not going to be as happy. So early on, it doesn't look like there's much happening at 10 years. Those patients who also had the worst symptoms, 20 or greater, resolved those symptoms, so they went to a lower category of urinary symptoms much more quickly than those who had minimum symptoms. So it took, on average, almost 5 years to get back to baseline for men who presented with minimal urinary symptoms. We found there really wasn't a substantial difference between men who got hormonal therapy and those who did not. Keeping in mind that many of the men who got hormonal therapy had bigger prostates, but certainly there were a lot of men in here who got hormonal therapy because they were higher risk. So you saw a less rise in urinary symptoms compared to the ones without hormones, and a slightly quicker return to baseline, but not that much difference when you looked at 10 years. So now this is what we're going to be publishing in the BGUI, and I presented this at the AUA. It's the 15-year data on what happens to urinary symptoms. And when you look at the factors, which we'll look at, terms of the presentation, men who presented with moderate or severe symptoms were slightly older. That's no surprise. They had slightly larger prostates. There was more use of hormonal therapy because of that. The use of external beam boost, which wasn't used in low-risk patients, but that was not different by treatment group or by symptom group. And the doses used, these are BED doses of close to 200 gray, were no different whether they had mild symptoms or moderate or severe symptoms. So this is the news I think that we need to pay attention to. So what I did here is I looked at the preponderance of men, so majority of men present with minimal urinary symptoms, and the likelihood that they would be free from going to moderate or severe symptoms over time. And so at 10 years, it looks pretty good. Only about 25% of men went from a low symptom category to a higher one, but at 15 years, it's 60%. That's pretty sobering. So it's just like survival. You don't see much going on at 10 years. with the different treatment groups, that at 15 years you start seeing a lot more prostate cancer mortality. And the same is true with urinary symptoms. It looks like now at 15 years you're starting to see a lot more urinary symptoms. Now, it doesn't break it down. You could go from a 7 to an 8 and you get into this group. But it is one way to look at it. And the mean time to the change, which is the change from a low group to a higher group, was 13 years. Here's the same analysis with external beam. So this is without external beam boost. This is with boost. And you can see that at 10 years, the curves aren't that separate. But as you get out to 15 years, you see a 13% difference in the likelihood of progressing to a higher symptom group, with patients who get external beam doing far worse than those who got brachytherapy alone. So what are the factors that influence this? So here's a Cox regression looking at the associations. So age was not significant. An older patient didn't move to worse symptoms than a younger patient, but external beam boost was a factor. Alcohol use was a factor. High blood pressure, probably because of the medications they took. And a dose above 200 gray was also significant. So if you delivered more than a 200 gray BED, so 200 gray BED would be D90 with iodine above 190 gray, or it would be combination therapy of 45 gray and more than 110 gray of iodine. If you got that much radiation, independent of external beam boost, there's about 27% chance that you're going to develop worse urinary symptoms. So in our practice, if we got 210 or 220 gray, it didn't really bother us, because over the years it didn't look like that was causing any problem. Now it looks like that longer term follow-up, we are starting to see some issues with urinary symptoms with the higher doses. And I'm not so sure that whether you get 200 gray or you get 195 gray, that's going to make a difference. So I've asked Richard, and maybe he'll get one of the residents to do this, just like he did the dose response study with D90 and then a dose response study with BED. I think we need to do a long-term dose response study and try and match biochemical and local control and now survival with a dose that doesn't give us or doesn't give as many urinary symptoms as we're seeing here. That's going to be an important next step that we should try and figure out. It's no question when you give a patient 200 gray with an implant, the local control is 98% by biopsy. That's far superior to prostatectomy. Even with low-risk patients, you don't have 98% local control. And with intermediate-risk patients, it's about 80% to 85% local control. So that means a 10 to 15% local failure rate. And with high-risk patients, it's probably 50%. And we can implant a Gleason 9 with 200 gray and still have 98% local control. So what about patients who've had prior prostate surgery? So you see a patient like this, it's a big cavity in his urethra from a prior Terp, and you see the catheter there. So if you're taking a patient like this and you're putting seeds in, and the seeds are going in like this, that's going to be a problem. This area of the urethra has very poor vascularity because of the cautery of the TUR, and the radiation over time causes endarteritis and obliteration, and so this whole area will slough, then calcify, and then it becomes a nightmare for the patient. So you do not want to do an implant in a patient like this, but you can do an implant. You can put the seeds well away from the cavity like this. You're still going to get good dose here, and you'll get good dose out there. So this type of patient is not impossible to treat. And I would argue that if you did a radical prostatectomy on him because of this big cavity, he would still be at a greater risk for incontinence. So these are challenges, but they're manageable. We've all had the experience when we finish an implant that, we've got 3 seeds in, 3 seeds left. Let's just put the 3 seeds in because I don't want to have to send them back. And how much harm could 3 seeds more do to a patient. So here we finished an implant, and the yellow areas, the red's the prostate, the yellow and tan areas are the 240 gray isodose clouds. So you can see there's about 55-60% of the prostate from this slice anyway, covered by the high dose regions, and the green line is 160 gray. So this implant already is got a D90 of 209 gray, which is pretty high. But the important part is you can see the center of the gland where the urethra is not covered by the high doses. So a properly done implant distributes the activity to the periphery of the gland where the cancers are mostly, and spares the gland, the center of the gland, of the higher doses that can impact the urethra. So let's put 3 more seeds in. There you go. Now look what happened. The yellow, which is the 240 gray, covers the entire center and periphery of the gland, and just 3 seeds out of, this is probably 75, 80 seeds, that's just 3%, 4% more seeds. It's dramatically changed what's going to happen to this patient. Now, most likely he'll still be okay, but you don't know what happens to your patients 5 or 10 years later. Your patients go off, they move to different communities, they go see a urologist who doesn't know much about brachytherapy. Unfortunately, there are more of them today than fewer. And the patient has some obstructive symptoms, but the obstructive symptoms are not from an enlarged prostate, because over time these prostates shrink 50%. They're because of these patients got a restriction in his urethra from the radiation, which has caused fibrosis. But a urologist knows what he knows, which means, or she knows now today, we have a lot of women urologists, that patient's being bothered by obstruction. So I'm just going to go ahead and do a TUR. Well, that is a major disaster to do a TUR in this patient. So the advice here is, and it's a general advice, and make sure you tell your patients, if you go off to see another urologist, that urologist should never operate on you without first discussing it with me. Unfortunately, they don't always do that. Write it down, put the note in your chart, because I've been to many of these cases, legal medically, where that's exactly happened, and the urologist who did the TUR, and then the patient's totally incontinent afterwards, and that patient goes back to that urologist who's done the TUR, and these are some very famous academic urologists, tells the patient, well, it's not my fault. It was that guy who put the C's in you. He caused your incontinence. So all of a sudden you find yourself in court now being sued by the patient, whereas it was the urologist who did the TUR who was at fault. So document in your chart you've advised the patient so. What about large prostates? Is there a size limitation? So again, the American Brachytherapy Society had said you shouldn't implant a man with a prostate more than 50. So we started doing it. We said, okay, we're fine with 50. We published some papers on that. Then we went up to 75. We're fine with that. Then we went up to 100. Then we said we have no limit. In fact, the largest prostate I think we ever implanted, Richard, was like 202 cubic centimeters, and that was after the hormonal therapy. And we also found that we could do a very good implant. In fact, the larger glands had hotter implants than the smaller glands. It's actually harder to implant a prostate that's 10 or 12 cc's than it is to do one that's 100. And the other thing we have to be aware of is we have to make sure we know whether that patient has an intravesical lobe, because if you don't know that ahead of time, then you end up not ordering enough seeds. What about hormonal therapy? What hormonal therapy should we use when we're trying to cytoreduce the gland? So this is a study we published comparing combination therapy, so that's Lupron and an anti-androgen, or Lupron alone, LHRH alone, or a combination of oral agents. In this case, it was flutamide and finasteride. So you could see by 3 months, you got the most shrinkage when you use combination therapy. It was about 33%. If you want to continue it for another 3 months, you can, but you don't get a lot more, maybe another 10%. So here's the case I was talking about. The patient's in the office and he has an ultrasound. So there's a sagittal image of the prostate, and he's got a little bit of intravascular extension, But the problem here is the urologist is looking at it, and he's not perfectly in the midline. He's a few degrees to the left of the midline, and he's not seeing the entire intravesical lobe of the prostate, which is really this. It's way the heck out here. So he's measured the volume as 60 because he's assuming that this is the length of the prostate. In fact, that volume was closer to 200. And when I brought the patient in and I put the probe in the rectum, I said, oh my God, look at this intravesical lobe. Then I scoped the patient. There was almost as much prostate inside the bladder as there was under the pubic arch. So that's what it looked like. It was really not 60, there's 60, it was really 204 cubic centimeters as prostate. So as I said, over time, prostate glands shrink, and it didn't matter if the gland was above 60, the red, or below 60, they all shrunk about 50%, and their urinary symptoms decreased the same. There's the data on implanting. That's the first paper we published on large prostates, more than 50. You could see this was a fairly early experience. This was published in 2000. There was only one implant out of this group that had a D90 less than 140 gray. What about the use of hormonal therapy and urinary infunction? So we were giving hormones to neoadjuvant hormonal therapy just about every patient who came with a gland greater than 50. So after doing this for a number of years, I started getting complaints from the patients, not from the implant, but from the use of the hormonal therapy. So we just asked ourselves, why did we choose 50? Well, because the ABS had said you shouldn't implant above 50, so we started giving everybody hormones if the prostate volume was more than 50. So we stopped. I said, I don't need to do that. So we stopped it, and then at 75, we said, well, maybe we'll go to 75, and we stopped it there. And so we sat down and we analyzed this, and what we found was that you really didn't need to use hormonal therapy unless the patient was symptomatic. So if the patient presented with a AUA symptom score above 15 and a large prostate, that's probably not a patient you want to implant because the retention rate was much higher in that scenario. So it wasn't that the urinary symptoms were bad. They all got bad symptoms the first 3 to 6 months, but the retention rate was worse if they had a lot of urinary symptoms with a large prostate. And the worst thing for a patient after an implant is to have a catheter in and the constant urgency with that catheter caused by the radiation on top of the uncomfortable catheter. So that was an indication to us to absolutely use neoadjuvant hormonal therapy if they were symptomatic with a large prostate. And this shows you the resolution of the urinary symptoms was quicker with the hormones and didn't go as high, but at the end, several years out, the symptoms were the same. And there's a retention risk. It was 5% versus 25%, so the odds ratio of 6.3 if the IPSS was 15 or above and they didn't receive hormonal therapy. Well, what about implanting a gland more than 100 cc's? I don't think there are too many people that would attempt to do that. It really is a challenge. And one of the major worries, of course, is pubic arch interference, because if you can't get the activity lateral and anterior, so that would be from the 10 o'clock to the 2 o'clock position on the prostate, you're not going to do a good implant. So we took a look at our patients who had a prostate volume less than 100 versus 100 or more, and there were 34 patients with a huge prostate in the database of 2,055 men, and there was really no difference. Only difference was PSA was higher, of course, with a bigger prostate, but Gleason score was the same, stage was the same. And interesting, the initial IPS was no different. It was 7.4 versus 8.5. The prior Terps were not any different. 88% of the men with very large prostates got hormonal therapy versus 54%. And the doses delivered were exactly the same by BED group to the two groups of patients, and this follow-up was the same. So what happens if you get into the OR and you go to do the implant and you can't get the needles in because you're hitting the pubic arch. Now, it happens a lot more often with big prostates, but I've seen it happen with prostates that were as small as 25. So we developed this two-phase technique, which is you put the needles in, and don't start with the needles on the bottom, because if you start with the needles on the bottom, it pushes the prostate up, and then you're already going to be in trouble. The first place you should ever put needles is here on the side. This is where the pubic arch is going to be, because you'll know right away whether that patient has pubic arch interference, and you can pull the legs back further to pull the pubic arch out of the way. You can only go so far. Remember, if you're doing an older man, he's got brittle hips, and if you over pull the legs, you don't want to cause a worse problem. So in this patient, we put the needles in, and we put them over here, and we push the probe all the way to the contralateral side. So when you push the probe over, it pulls the prostate with it, because the puboprostatic ligaments have some laxity to it, and it opens up the space. But when you do that, there's no way you're going to get needles over here. So we put the needles in here. Now keep in mind, we're using the computer, so everything is being recorded, so we know exactly where we begin and when we end. And we stop, and we go as far as we can. And then we just do this implant. And then we pull the probe over to the other side, pull the prostate the other way, which opens up this side, and then this patient had a double problem. You could see his one leg is down and one leg is up because he had a bad hip. We pull it all the way over to the other side, and then you can put these needles in. So you can do the entire periphery, because we do our implants in two phases. We do the periphery first, and then we do the interior second. And you can get a nice implant this way. So people say to me, "Do you ever have an implant you couldn't do?" And I said, "I've never met a prostate I couldn't implant." And that's this patient. This is what it looked like afterwards. He got a palladium. This was the guy with the 200 prostate. He got a palladium implant. He's getting an external beam, and you can see the fiducials there for the markers, and you can see how the pubic arch is pushing the prostate. And once we released it, it went back to pushing it in, but those seeds are already out to the capsule. You can see the intravesical lobe. This guy had high volume glycinate, and he was cured with the combination therapy. So when you look at the analysis of biochemical control in this group, you can see that prostate volume was not significant, and the dose was. What about urinary retention? These are the incidences of urinary retention that you see published in the literature, from a low of 1.5%, which I think is pretty low, to a high of 22%, and we run around 7%. So Mitch Turk's article was 5. It's between 5 and 7%. It's interesting, people ask me when we're doing the mapping biopsy, because the mapping biopsy is similar to an implant. You're putting in needles like you do an implant procedure. That's why it's very intuitive to physicians who do prostate seed implant to do a mapping biopsy. And I just published the retention rate for mapping biopsies is 7%, which is what you would expect, because that's what we saw with brachytherapy. So how do you manage obstructive symptoms? Well, we use full-dose alpha blockers, and sometimes, even though the literature says if you have a man with urinary symptoms, putting in 2 tamsulosins doesn't really help. It does, I believe it helps with acute urinary retention after brachytherapy. I've even gone as far as using 2 in the morning and then adding terazosin at night to help with the night symptoms. Just be careful. You tell your patient that he's got a lot of alpha blockade in there, so if he's getting up at night, just to sit at the edge of the bed and dangle his feet so the blood pressure can equilibrate, because you don't want your patient getting up, getting dizzy, and falling and breaking his hip. Now, I also found anti-inflammatory medications and also work. I've not used PDE5 inhibitors, but there may be some benefit from putting a patient on daily low dose this along with an alpha blocker. So the worst patients who are the worst after brachytherapy in the first month or two are those who have severe obstructive and irritative voiding symptoms, because they have to get up all night long to urinate and they can't get it out. So they're miserable. So I've started to use diphenhydramine low dose at night. I found that works very well. It does not put, in my experience, it did not put patients into retention if they're already on alpha blockade. It allowed them to sleep because it's a sedative, and it helped cut down on the urinary symptoms. If that didn't work, I would go to a low-dose anticholinergic. Make sure you check for narrow-angle glaucoma, because that's a contraindication to using these drugs. What about prolonged retention? Should you do clean intermittent catheterization, or should you just go right to a Terp to make that patient happier? Keep in mind, you don't want to remove seeds before the half-lives, at least 5 half-lives have passed. So Terp rates following brachytherapy, you can see the rate here. Ours was about 2.4%, and the range from 0 to 8.7%. Kent Wallner was at Memorial with this data. And these are all the well-known brachytherapists, Mike Tottoli, Gregory Merrick. So one of our residents reported out our experience. We had about 2,500 brachytherapy procedures. Patients who had a pre-TURP were excluded. So our numbers were 3.3% of the patients had a TURP following seed implantation. The median follow-up after implantation was 7.2 years. The median time to the first post-implant TURP was a little over a year, with a range of 6 months. So palladium you can do in 6 months to 188 months. So there's some that were done well over 15 years afterwards. 20 of the 79 patients had incontinence. So it's 25% incontinence rate versus 3% if they had no post-implant TURP. So the odds ratio was 10 times. There was a 10 times greater risk of incontinence if you do a TURP after a seed implant, which tells you do not want to do a TURP. So if I've had patients who are still in retention 3 months later, actually I don't wait more than about a month. If they're not out of retention a month, I put them on clean intermittent catheterizations. And I've seen patients start to urinate 6 months afterwards, 9 months afterwards. I just tell them, wait. I say, you're doing fine. Prostate's going to shrink. It's going to shrink 50% over time. You'll get out of retention, or you can have a 25% risk of incontinence. None of them give up CIC when I tell them about that data. And so there's a difference. No TURP. Gosh, if you do multiple TURPs, it's even worse. You go from 24% incontinence risk to 56%. Half the patients who've had multiple TURPs get urinary incontinence. You know, we give high doses and there's not a lot of blood supply to the center of the urethra, and you cauterize it when you do a TURP and you do it again, you're just asking for trouble. And there is the Kaplan-Meier curve. So basically what this tells you is that the risk of incontinence may not ever disappear. That's the Kaplan-Meier. So bottom line, CIC for at least a year. If you're going to do a TURP, it's a minimum channel TURP. You want to preserve the blood vessels at the bladder neck at the 5 and 7 o'clock position, because they feed that urethra that doesn't have a lot of blood. Utilize minimum fine cautery. Avoid laser and widespread tissue destruction. If you're a radiation oncologist, you got to keep on top of these patients and make sure they go to a urologist that knows what he's doing, because he's had experience in managing patients that have had radiation. I'm going to skip the flare. Hematuria, here's a paper, another resident published from Mount Sinai on about 2,500 patients looking over a 20-year period, and men who had gross hematuria. So 8.9% of the men develop gross hematuria. So if they get hematuria, you have to evaluate them. And the hematuria appeared a median of a little over 2 years after implantation. There's a time frame. Most of these are happening within the first 2 years. Then there are a few happening later on. There's a freedom from failure for developing hematuria. And this is a logistic regression looking at the variables. So what was significant here, people who had biochemical failure were more likely to get hematuria, and large prostates and external beam irradiation. So there's no surprise there. So what were the findings at cystoscopy? Another paper from our resident. So a total of 185 men who underwent cystoscopy for hematuria or refractory urinary symptoms. So this is the freedom from having a cysto, 10-year likelihood of being free of requiring a cysto was 89%. So 11% of the men, roughly, ended up having a cysto. And what they found, mostly there was no reason. Majority of the cystos were negative, small minority, big prostate, 2% had bladder tumors, 6% had radiation cystitis, 5% had inflammation. There was a stricture present in 10%, and a stone present in 2%. So you want to find these bladder tumors. The incidence is very low. As Dr. Crooks had shown on the data from Cleveland Clinic, there's not a lot of tumors associated with bladder cancer, with prostate brachytherapy, but you still need to take a look. So there were 18 bladder tumors. The incidence was 0.7% out of the 2,500 patients. The median time to detection was 3 years, with a range of 8 months. So these were probably there and missed initially, out to 14 years. These are probably after the implant. They came out. 1/3 were diagnosed within 2 years of radiation therapy. So 6 of the patients probably already had issues. 13 were identified as low grade, 72%, non-invasive. 3 patients had high grade non-invasive with concomitant CIS, and only 2 patients, so 2 out of 2,500, so less than 1%, had an invasive tumor with 10 years follow-up. Don't leave seeds in the bladder, because this is what you end up with. That's a stone with a seed in the center. And if you're doing a Terp, this is a nice small channel Terp. You don't want to be looking at this. This is a patient I saw who was incontinent after he had a Terp by another urologist. You get these fluffy exudates, which are basically necrotic tissue because nothing heals in there. How do you manage incontinence? So you have a patient who has mild incontinence. This is stress incontinence. And he's got a sphincter that's not so patent. And this TUR channel was probably brought too far distally. That's the type of patient, because this is compliant tissue that can be managed with a collagen injection. So here it is. Before, there's the needle going in, putting the collagen in. You can see the verumontanum, and everything's closing up nice, and there's the end product. So this patient did very well with a collagen injection and cured his incontinence. Here's a patient who had Gleason 10 prostate cancer, T4. So the cancer had grown from his prostate apex out into the urogenital diaphragm. It was actually out into the levator muscles. That's how bad it was. So he got treated with palladium external beam and 2 years of hormonal therapy. I even implanted the area outside the prostate that had the cancer in it. He was completely cured. He had a negative node dissection. Gleason 10 T4 cured. But 10 years later, he started leaking urine. I looked inside, and this is gaping wide. No surprise based on what we did with him. And I tried to put collagen in him. It was stiff as a rock. You can see it's just barely under the mucosa. It did absolutely no good. So that's a waste of time. That guy needed to have a sphincter to treat his incontinence, which he didn't want to have. He was already 80 years old. If you run into these situations, you just want to strangle the urologist that put you there. So this is a patient that we implanted, Richard and I. He had like a 60-gram prostate, didn't get hormones. He had horrible urinary symptoms afterwards. But this is really personality-driven. He could have just waited it out, but he didn't want to wait it out. So he goes, says, I'm going to get a TUR. And I said, oh, I'm not doing a TUR on you. He goes, well, I'm going to go to my urologist in New Jersey. So he goes to the urologist, and I said, give me the name. I'll call him up. I'll tell him not to overdo it. I call up the urologist, and urologist says, I know better than you. I treat a lot of patients with BPH. I said, this is not your normal patient. So he didn't want to hear from me. So he went and did the resection on him, and patient called me up and said, I'm so happy I can pee now. I have no problems. Well, I said, okay, you'll be calling me back in 3 or 4 months. Sure enough, he went into retention. He goes, I'm going back to the urologist. I said, don't do that. I called the urologist up. I said, look, just get rid of the retention, minimal work. Went and did another big TUR on him. So now there's very little prostate left. And he comes back to me 3 months later in retention again. I couldn't even get a catheter in him. I'll show you the picture. So when you manage these patients who've had TURs and develop strictures, you want to manage the stricture first by doing a minimal urethrotomy or dilatation, and you put the patients on self-cath. This has been a very successful way to manage these difficult post-radiation strictures, mostly caused by some form of manipulation. So you put the patient on a catheter. He catheterizes every day. After doing that for, say, 1 or 2 months, I tell him, decrease it to every other day. He does that for a couple weeks, then every third day, etc., until it gets down to once a week, then once a month. And I say, as soon as you feel that your urination starts to decrease, go back to every day and then back off again. I've had 100% success in managing patients with that. That allows the urethra to rehabilitate and allows some of the blood supply to return to the area. So that's a really good way to manage. And if you bring that patient back and you do another TUR on them, you're asking for a worse situation. I showed you the incontinence data. So here's what this patient, he came in after his second TUR, I scoped him, it was just a wall of calcification as soon as you hit the verumontanum. I couldn't get a wire past this, never mind my cystoscope. So he was 64 years old, his D90 was 194. I told you the history, another Terp, retention. Here he is 2 years later now, he's got this wall of calcification. I wasn't able to get anything in him. So I brought him to the OR, I put the catheter, put a wire up, got the scope in, I just knocked off the stones. I didn't do any surgery on his urethra, just got rid of the stones. That went on for several months, and I would leave the catheter in for a week, bring him back, take the catheter out, he'd come back 3 days later in retention again. And I couldn't get a wire or catheter in, so I said, finally, I'm giving up. And I couldn't get him to pass the catheter because he would just go right back into retention. So I remember when I was a resident, I trained in a program where we did a lot of posterior urethral stricture surgery for trauma, which is very difficult. And my chief had taught me to put a council tip catheter in with a wire through it. So the wire goes through here into the bladder and comes out the urethra. So that's what I did to this guy. And then we had a catheter on the end, and then he could push the catheter in, and when he hit that tough area, he could pull on the suprapubic wire or suture and pull the catheter into his bladder, and it worked. It took him a year. He did that for 1 year, and finally the urethra healed. And now he doesn't have to do this anymore. So that's the worst case scenario. I hope you never see it, but if you do, you'll know what to do. So we also did a paper on urinary symptoms, erectile function. So using the SHIM score, and we defined potency as those patients who came with a SHIM score equal to above 12 and then remained above 12 at their last follow-up. So this is looking at race and the percent of potency preserved at 10 years. With race, and there's no difference. The potency preservation by race was the same. So it was about 66% of men at 10 years had their potency preserved with this score of 12 or higher. And this is a busy slide, but when you look at 12-year potency preservation and the issues, of course, age. If the patient was over 65, only 32% preserved potency, but if the patient was younger than 65, it was 52.6%. Now it looks like dose again causes some degree of potency loss. Hormonal therapy does. P was less than 0. And what else involved here? Some of the things like heart disease and AFib. Low testosterone did not do it. So it doesn't look like low testosterone, at least below 300, was causing any issue. So dose, age, and hormonal therapy are factors that influence long-term potency. But we're able to preserve potency about 60% of men at 12 years is pretty good because they lose potency anyway just with age, and these patients are 12 years out. Looking at the Cox regression, you see age again is significant and hormonal therapy. So the longer this total hormones means the length of hormones. So the longer the hormones are used, the greater the likelihood that a man will not preserve. They're recovering their potency. They're just not keeping it as long as men who don't get hormones, who get shorter term hormones. So that's another argument not to give hormonal therapy for too long. Thank you.